Later, she still stands on her foot. It's not ideal foot, and she is, in addition, using a brace, but she is still walking on both feet. So, to conclude, what can a surgeon do? Unfortunately, not a miracle. But we have given you quite a lot. An orthopedic surgeon called Banting, namely discovered insulin and gave it to endocrinologists kindly. So we do deserve a little bit of respect after all. And we can help our patients, diabetic patients, with various methods. Offloading, closing the wound with different flaps or the skin, correcting deformities and stabilizing the foot and ankle. Limb salvage is important, and we can prevent amputation in neuropathic feet. This would be my take-home message, but we all need to work on that project. Thank you, and this is the highest mountain of Slovenia.
It was a fantastic talk. You lived up to the expectations. Any questions? What shall we do? Shall we take the questions for all the speakers together? Yes. Is that right, Anjana, Shyam? Yeah.
Thank you very much, ma'am. We all know that surgeons do play a very important role in management of diabetes. So the problem, especially what we face here, is a dearth of the foot surgeons. I think if people like you, involve more doctors, orthopedicians, they can inculcate the interest, because foot surgery, foot problems need a lot of dedication. They need a lot of motivation from the patient side and the doctor side, because it takes a lot of time. So all these things are there. So there's really a dearth of such good surgeons in our country. So, and being a country where rural practices are very much, and we see a lot of diabetic foods from the rural population, and invariably they land up in amputation because of dearth of such centers in our setup. I thank you very much for enlightening us, and thank you so much, ma'am. Yeah.
In case you're thinking of relocating to India, we'll speak to Modi for the citizenship. Any more questions? Can somebody pass the mics to them, please? Yeah. We got a few mics here. Yeah.
Wonderful talk. My only quick thing is, both of you told that the gold standard is total contact cast. And Professor Boulton made a remark that, let the ulcers stew in its own secretions. So, but in this humid country of ours, we are scared that they may get infected, putting a diabetic into a cast. So, your advice on, creating a window in the cast?
It works. Yeah, I think this could be a solution, yeah. Even though the dirt will come in, that's the other way I wouldn't be so fond of. So maybe...
I suspect you don't need to worry as much, because the original studies were done just in this climate, in leprosy patients in Vellore and Karigiri in Colombo, and the reports came from there before the days of antibiotics. I think that if you've got a non-infected neuropathic ulcer, the key thing is to remove the cast frequently, and I'm sure that Karen would agree,
yes,
because the cast can harm an insensitive foot. So we move our casts after the first week, the second week, and then if it's okay, every 2 weeks. And then you can inspect. If there's any suggestion of infection, you can add antibiotics. And you can put a window in, but as Karen says, there is a risk there.
Yes.
But there isn't that edema effect that people worry about.
Also, sometimes I compromise, and I do not put a boot on, but I only put a cast shoe. But these casts are made of a special material. It is not, it's not all the same material. It's two materials, in fact. One of them is a Scotch cast, and the other one is a softer, more elastic band. I would maybe go for shoes in your country, because boot is really hot, yeah.
it clear in my talk that there is no evidence at all to support the use of hyperbaric oxygen, local, systemic, at all. The only one small trial that suggested it might be useful was in patients with neuroischemic ulcers with distal vascular disease beyond the possibility of bypass or angioplasty with chronic infection. And that has been negative. It's extremely expensive waste of money in my view. We can't afford it. And the cynic would say it's an effective way to offload the foot because you can't walk around in a chamber.
But here in Hyderabad, we get it free at the Dundigal Air Force.
But, so if something's...
hyperbaric oxygen, and we do find, I have treated 4 or 5 patients, not many, with hyperbaric oxygen, and the result was good. Amputation was prevented.
In a chamber?
In a chamber.
The good thing is they can't walk about for its use, and if something's free, it doesn't mean it's good. It may have a place, but we're yet to see a good trial, and that's what this Dutch one, I think, will answer, in a large number of patients properly randomized. That's the problem. It may work, but I'm yet to see proof. That's what I'm saying.
But were those ulcers purely neuropathic ulcers?
Yeah, they were neuropathic.
But, you know, then in that
Not
case...
only, no, it's not only neuropathic, as you said.
Okay,
Yes.
if it's a mixed ulcer, a little bit of vascular impairment, there may be some gap for that therapy. But if it's a pure neuropathy,
No, it's not a pure
all you
neuropathy.
have to take is hyperkeratosis and pressure away, and it will heal.
Because the surgeons have asked them to get amputations, and then we as a physician have stopped that time. We could prevent them from amputation.
Okay, I get the point.
I have one last question for Prof. Noticed that people are very sensitive to pioglitazone and the glycemia. And the practice here is that if there is a cardiovascular risk factor or a previous history of MI or heart failure, they use negligible dose or no dose at all. Would you allay our fears? Would you say it is?
I think pioglitazone, as I said, has been because of false claims about side effects that haven't been proven in large 10-year follow-up studies. Of course, they do lead to fluid retention, and you need to be cautious there. Pioglitazone, I think, especially in the insulin-resistant patient like yours, I think lower doses are needed in your patient group in Asia, in Indian subcontinent Asia, and I think it's a very useful drug. It's the only drug we have that tackles, insulin sensitivity or lack of insulin sensitivity, and it's not associated with hypoglycemia. The proactive trial, unfortunately, they put in 2 endpoints that were subjectives. The moral of that story is never have a medical trial designed by a surgeon. I'm sorry. It was a vascular surgeon. And they put in 2 endpoints, and I'm sure our colleague here would agree they shouldn't have been in. They had cardiovascular endpoints, which are hard endpoints like coronary or acute coronary event. But 2 of them were amputation, and that depends on the surgeon and the patient, and revascularization. And they're soft endpoints because they're not controlled. And I think the proactive trial would have been positive if you hadn't have had those 2 endpoints in. And if you look at sub-analyses, they're a very useful drug. I'm only teasing. He would agree, I'm sure. You can hit me back.
No. Totally agree with that. As you've shown in your papers, the Hispanics are termed as non-reconstructable, whereas the white population were operated for the revascularization in America. So they are soft endpoints, isn't it? See, you're done with the question.
Normandy, you know him, I know him.
The other two questions to Karen here. When do you do an angiogram and a diabetic foot? You can't always be certain that it's a neuropathic ulcer. Sometimes you do get the mixed ulcers and the vascular ones. And what's your indication for the angiogram?
Well, if I'm not certain about it, we have a sort of angiology department in our country. That's a step towards vascular surgeons, and they do all the testing. And also, whenever I'm thinking of major reconstruction, I sometimes decide to check the vascularity as well, especially in older patients, even if I have palpable pulses. But I want to do major ankle surgery, and you know how ankle is after surgery. It is swollen. And if you have, in addition, some vascular problem, it's going to be amputation afterwards. So this is where I decide for diagnostics.
And the other thing is, you remember that you may know this vascular surgeon George Andros from Los Angeles, a good friend of mine, a typical American, still working, and he's over 80, I think, they never stop. But he wrote a paper in 1984, if a diabetic foot ulcer doesn't heal within 4 weeks, even if there are palpable pulses, do an angiogram. He's probably right.
Yeah, he's probably right. The other one is, you mentioned about the white cell scan for the Charcot's. Do you do MRI these days for the bone infection?
MRI we do use in Slovenia more and more, also for recognizing infection, but I have to say I'm more modest. So I start with a properly taken wound swab. Usually it takes long enough on the X-ray to be seen. The more I'm using it in differentiating between Charcot and infection, which sometimes is puzzling, especially in a case I showed where it's both. It's possible you have both in the same foot. So for those I would need other investigations, but unfortunately our X-ray technicians, radiologists are not trained properly yet in Charcot. So I get the answer, it is either arthritis or osteomyelitis or Charcot. So I'm left with the same questions I asked. So yeah.
Similar here, actually. Probably anywhere in the world, isn't it, these days? Yeah. Yeah.
Thank you. I think in the interest of the time, we have to conclude the session. Thank you very much, all the speakers, and thank you all for the chair. I invite Dr. Venkataswamy, consultant orthopedic surgeon, to please hand over a memento to our guest speakers. Dr. Sham's wife. Dinner is ready, and
it's not mine.
Yeah.
Just take it.
Thanks.
Whose is this? It looks like the FSD one.
Time, I think we will conclude the last session. Dr. Ravi Shankar, any suggestions for the audience, rest of the chair members who are the, I don't know. Prof, any questions you want to take? Because I know you are getting... anything you might want to ask the Prof before he disappears to Bangalore tomorrow? I particularly want to thank Dr. Srinivas, who has been my classmate, but actually these things happen behind the screen with Srinivas' input. And I think vote of thanks should go to Novartis' son, Dr. Reddy's. I think it's time that we stand up to improve our healthcare system. We need to work with technology. We need to have databases. One of the intentions of our group is to try and see whether we can this. I think we will probably, I apologize again in the end for the delay. It's sort of unexpected. I had to cancel the last session for that thing. I apologize for that. Thank you very much. Thank you, speakers. Thank you, Chair.
It's a growing one, but not only in India, across the world. And much of this is due to, sadly, westernization of your society. When I first came here 30 years ago to this wonderful country, I didn't see any fast food restaurants, I didn't see any Dunkin' Donuts. Walking, rather than the car, taking the stairs instead of taking the lift. These are simple steps that really have a big impact on reducing diabetes. Which sadly is growing rapidly. Another problem is early diagnosis. Many people, when they find out they have diabetes, they've had it for a long time. They may come out with complications. So those who have family history, those who are sedentary, those who are overweight, and these are people who should be screening. Screening, early prevention, and early treatment will reduce the burden of late complications. Diabetes is a serious disease. It's actually